Now I would like to invite Dr. Gemini Isac. She is consultant neuro-ophthalmologist at Chaitanya Eye Hospital, Trivandrum. She'll be talking to us about the emergencies you commonly see in neuro-ophthalm.
Good afternoon, everyone. This is the last talk in the multi-specialty session, Emergencies in Neuro-Ophthalmology. And what is an emergency in ophthalmology? It will be either vision-threatening or life-threatening conditions or both. So, around 90% of cases of neuro-ophthalmology will be either vision-threatening or life-threatening. So, I won't be able to do justice to the topic within 7 minutes, I think. So I decided few topics which I personally feel difficult to diagnose and manage. Let us go to the cases. First case, papilledema itself, we know it's due to raised ICT may be due to ICSOL or idiopathic intracranial hypertension or raised ICT secondary to CVST or dural AVMs. So this is a case of 13-year-old girl. Her elder sister, it's a case of congenital fibrosis of extraocular muscles. The mother used to bring both the children to our OPD, and one day she contacted a new pediatric ophthalmologist consultant and told, "Ma'am, the second child, the younger one, also has squint, sudden squinting with the double vision." And she told, "Ma'am, you told the elder's condition is a congenital condition and the younger will be safe, but she also developed sudden onset squinting. What will we do?" These are means especially mothers will be too much worried about the cosmetic things regarding the girl child, no? So ma'am asked any history of seizure, limb weakness, trauma. They told no, nothing like that. And she had 2 episodes of vomiting 2 weeks back, and she consulted locally, and somebody gave antiemetics, and it was okay only. So we called her for fundus examination. This is her fundus. This is a established papilledema. So detailed evaluation, detailed history, child told she had accidentally hit her history of hit on stairs 1 month back. She was afraid that she didn't reveal that history to parents, and in between this 1 month, the multiple episode of vomiting, that time they locally consulted and took some treatment, and the consulted people didn't do any fundus examination or imaging, and the MRI showed subacute SDH, right fronto-parieto-temporo-occipital convexity, and the child underwent right FTP craniotomy and evacuation of SDH on the same day of referral. The second case, so one 28-year-old male with a history of headache, transient visual obscurations, and blurred vision and tinnitus, binocular double vision, all symptoms of raised ICT, 2 weeks duration. He was working abroad. The time he consulted ophthalmologist, neurologist in USA. That time they found some raised BP. So they initially diagnosed as malignant hypertension, and he didn't get adequate treatment. Later his vision dropped to 6 by 60 and less than 6 by 60. So again he consulted ophthalmologists there in USA. Then this time they did detailed evaluation that papilledema is persisting, so they went forward with a CS of opening pressure by LP. And this time the LP found 34 centimeters of water opening pressure and diagnosed as raised intracranial tension, that is probable IH. And this is his field he produced at that time. That time itself it was a constricted field, very much constricted field. This is so again his vision dropped, and he wanted second opinion from his own country. He came to us. That is his vision on presentation to us. That is right eye 3 by 60 and N24 vision, left eye 2 by 60 and less than N36, pupil sluggish both eyes. This is a fundus picture. And we evaluated him. This is a male patient on Diamox from abroad, but not responding to Diamox. We evaluated with MRI and MR venogram, which show the extensive thrombosis of the all the sinus, the superior sagittal sinus, transverse and sigmoid. And MR angiogram also showed AV malformation, which is confirmed with the DSA. And status post AVF embolization, patient had again progressive drop in vision with the significant disc edema. So we thought of doing ONSF along with this. So B scan showed crescent in both eyes, that is perioptic CS of space widening, both eyes was present. So we selected right eye with poor vision, that is hand movements vision for the procedure, and we did ONSF, and 3 weeks late post ONSF OU both eyes vision became hand movements. We again did the imaging which showed the intervention radiologist missed means one residual AVM. So again he underwent closure, and by that time he lost his vision. So the message is pulsatile tinnitus, transient visual obscurations lasting for seconds, multiple episodes along with binocular diplopia and papilledema is a feature of raised ICT, that is IH or CVS, complicated CVST. So you cannot means benign conditions like malignant hypertension should not diagnose in such cases. So visual acuity along with visual fields is very important. OCT, RNFL and GCC will help you in diagnosing as well as your follow-up and visual prognosis. And VEP, if the patient comes to you at a later stage with pale disc, you can do a VEP also to assess the optic nerve function. Ultrasound B scan, if the discs are pale, you can assess the optic nerve sheath diameter. You will be able to know that the ICT is still is high, with the fluid is still there or not, which may cause progressive drop in vision. And MRI brain and or with MRV is the investigation of choice in papilledema, and MRA if the patient is a male patient to rule out AVM. Management, medical and surgical, TAP Diamos 250 mg the starting dose. You can give up to 1500 mg per day. If the disc edema or optic nerve sheath, increased optic nerve sheath diameter in case of pale disc, this is there with gradual drop in vision with the field constriction. That the message is 6/6 vision is not okay. 6/6 vision with extensive field constriction and persistent disc edema or optic nerve sheath widening, that is in a pale disc, you should think about either shunt or ONSF or both. So next case is multiple cranial palsies. The cranial palsies either isolated or multiple cranial palsies an emergency. 346 cranial palsies could be associated with space occupying lesions, either primary or secondary, ricebleed or infiltrating lesions, or even in space occupying lesions in the brainstem or trauma cases also you will get multiple cranial palsies. Commonly we people used to evaluate for orbital apex cavernous sinus SOF syndrome or brainstem syndrome in multiple cranial palsy in our scenario. And localization, cavernous sinus syndrome is the most common, followed by orbital apex and cavernous sinus. Investigations, blood investigations and imaging, MRI brain and orbit with contrast to rule out inflammation, infection, neoplastic and vascular pathologies, and compressive lesions along with toxic causes are there, especially patient is on chemotherapy. Vincristine, vinblastine are the causes for cranial palsy in a chemotherapy patient can cause. And another case is the 47-year-old lady. She's a high myope, noted defective vision in her left eye recently and locally consulted and was diagnosed as vision loss due to glaucoma. Since the other eye also has abnormal vision, she was referred to us for second opinion. She was on treatment for open-angle glaucoma both eyes. This is a best corrected visual acuity when she presented to us. Right eye 618 and N18 and left eye light perception, mild ptosis left eye, minimal abduction limitation, pupils anisocoria was there, left eye more than right, fundus examination, pale disc, left eye more than right with cupping. But cupping was present but pallor more than cupping. So partial third nerve, pupil involving, pallor more than cupping and loss of vision in one eye. We decided to image her in spite of this glaucoma medication and her history of glaucoma treatment. We found that this is a pale disc, this is OCT RNFL showing extensive thinning, and this is MR angiogram 3D reconstruction. You can see IC aneurysm. So the aneurysm compressing the nerve, third nerve as well as chiasm optic nerve. That was the cause for this patient's defective vision. So moving to the next case, carotid dissection. Usually the symptoms may proceed a mean interval of 6 days before acute event, including stroke or vision loss, sudden painful corner, transient visual obscuration, lower cranial palsies, ischemic optic neuropathy. These are the presenting. Usually, the patient's presentation will be with one among this. And investigation is CT angiography or MR angiography, which are non-invasive rather than invasive DSA. So, your treatment should be endovascular treatment and anticoagulants, because thrombosis is one of the cause for carotid dissection. Another case is neurophthal emergency case. This is pituitary apoplexy. It is not that common, but cases with some cases with pituitary adenomas, this neurosurgeons won't operate. They will keep them under follow-up with the visual fields like that to rule out if there is no compressive optic neuropathy, they won't operate some people. So in that cases, if the patient has any infection or a patient is on some radiation treatment or something, it may in any time they may get apoplexy. Hemorrhage or infarction into the substance of the gland, mass effect over the chiasm and other surrounding structures, vision loss, diplopia, and visual field defect would be bitemporal or junctional scotoma, cranial nerve palsy, third nerve with the first cranial nerve involved, followed by sixth and fourth. Could be unilateral or bilateral ophthalmoplegia. Endocrine dysfunction is life-threatening. Treatment of choice, investigation of choice is MRI, and treatment is endoscopic adenoma decompression.
We'll have to wind up in 2 minutes.
Yes. So, traumatic optic neuropathy, we know direct and indirect traumatic optic neuropathy. And the thing is, you will have RAPD, color vision defect, and field defect, but disc will be normal in initial stages, and your investigation, MRI, and your investigation should be not only CT cuts, MRI brain and orbit with the CT cuts axial and coronal. That will detect the fractures and as well as the status of the optic nerve. Treatment is IVMB, surgical management is decompression. IVMB, there is controversy. Most of the studies tells that there is no role, especially crash study. IVM patients treated with IVMB following head injury had a 6-month follow-up, mortality was more, that is the crash study. But in our practice, we know that is patients, when we give IVMB, it is response. In not all cases, but the dictum is if the patient gets some vision, we can explore all the possible ways. And atypical optic neurosis, the last case I want to discuss, that is in our spectrum in India, that are all the textbooks and all the studies says that retrobulbar optic neuritis, where the disc is normal, that is the common presentation. It's not like that in our scenario in South Asia. The papillitis or atypical optic neuritis with the bilateral disc edema is the most common presentation. So the treatment also, it is not going with ONDT, it is little bit different. So ONDT says if you treat or not treat, the patient is going to improve. But here in atypical optic neuritis, if you don't treat aggressively, the patient will be in wheelchair all the time. And the another thing we used to differentiate between typical and atypical is that the treatment for neuromyelitis optica is immunosuppression, plasma exchange like that means after the initial IVMB. And the disease modifying agents, interferons are contraindicated in NMO diseases. So, and the interferons are mainstay of treatment in MS. So, you need to differentiate both. So, 47-year-old lady, she presented with her OPD with this finding, one eye, corkscrew like vessels, and so we did gonioscopy, that blood in Shams canal, we imaged her, we found that carotid canus fistula, we referred to interventional radiologist, but what happened was they told, means because of her vision is normal, fields are normal, we will follow up her with carotid massage, and advised carotid massage. This is a 1-week follow-up picture. The patient presented with extensive proptosis and chemosis. The patient, the ultrasound B scan means showed SOV thrombosis. And GCA, we all know it is a sudden painless loss of vision associated in elderly male or female, associated with the headache, diplopia, myalgia, and jaw claudication. Fundus will show chalky white disc with affected side. ESR and CRP will be very high. Temporolateral biopsy is the diagnostic modality. IVMP for 5 days followed by immunosuppression for at least 1 year to be considered. Thank you for your patient listening.
Thank you, Gemini, for enlightening us with all your interesting cases and experience in neuro ophthalmology, and for all those take home